Using the suction device, you want to place the patient on the lateral recovery position. You want to then test the suction device by turning it on. You want to then occlude the pipe and ensuring that it gets up to 350 milliliters of mercury. If it does not, test for any leakages or any problems with the machine. You want to then test suction by occluding the end of the airway like so. Then insert the rigid catheter into the mouth only as far as it can be seen. Use suction in a circular motion only on the way out. Suction time should be less than 10 seconds. 5 complications that can arise from using a suction device is induced vomiting, induction of bradycardia, hypoxia, aspiration, and soft tissue trauma. And it is very important not to use a rigid catheter in a moving vehicle. With the bag valve mask, you want to look for any leaks. So to do this, you need to try and inflate the bag while sealing it off. This will show any leaks present. You then want to also fill up the reservoir to make sure that it also doesn't have any leaks. So you want to then assemble the bag. So to do this, the reservoir and also the mask, like so. And you also then want to attach the bag valve mask to running oxygen. So you'd want this to be running at a minimum of 10 litres per minute. So you want, and then whilst that's occurring, you want to assess if the reservoir is filling up. So I want to put this on to 10. So I can see here that the reservoir is starting to fill up, which shows that there is no leaks. So I also then want to perform a head tilt maneuver to open up the airways. You then want to insert an OPA or an MPA, so in this case I'm going to insert an OPA. So you want to measure this to your patient from their mouth to their mandible, and so you want to measure it and see if it's correct size and insert it at 180 degrees. Like so. So you want to twist and it should fit in like so. So you want to then fit the mask on the patient's head the correct way up, so that's the head in first, then the nose. So I'm going to do this like so. And since I am a single user, I'm going to be using the CE grip to ventilate the patient every 5 to 8 seconds. So every time I ventilate, I want to check for chest raises and gastric inflation. So there, when I ventilated, the chest rose, and that is what I'm checking for. For gastric inflation, you want to put pressure on the anterior and posterior cricoid ring, which is on the larynx, roughly located where the Adam's apple is, and this moves the trachea posteriorly and compresses the esophagus to prevent aspiration and gastric inflation. So generally, a second user would be doing this, and you also want to use the MOANS acronym to assess the effectiveness of the bag valve. For wound care and hemorrhage control, you want to check that you're wearing the correct PPE, so that is your gloves and your safety glasses. So you want to expose the wound and clean it with saline fluid if it is required. You can also pack the wound with moist dressings if necessary. But what you want to do is cover the entire wound with the smallest possible dressing to enable the maximum amount of pressure. So what you want to do with your bandage is fold it, like so, and place it on the wound area. So for a small wound, you can use an adhesive dressing, but for larger wounds like this one, you want to bandage over the dressing, twisting and tightening the bandage each time it travels over the wound. So once you have dressed the wound, you want to check to ensure that the bleeding has been controlled. If the bleeding has continued, a second dressing or bandage can be placed on top, or you can choose to elevate the limb, like so, or also placing indirect pressure on the wound by placing a second bandage under the armpit area. For catastrophic hemorrhages, you want to apply a tourniquet, so this needs to be done at least 10 centimeters proximal to the wound. Once this is done, you want to tighten the windlass until bleeding has arrested or diastole pulse disappears. And if bleeding is still profuse, apply a second tourniquet, and always remember to record the time of application on the white tabs located on the tourniquets themselves. So now I will demonstrate how to use a tourniquet. So you want to apply it 10 centimeters proximal to the wound, like so. Twist the windmill and apply the time strap. So this is when you will then place the time of application on the strap itself, and also then feel for a diastole pulse and hope that the bleeding will have stopped. For an eviscerated abdominal wound, you want to apply a saline soaked dressing and also cover that with cling film. For a sucking chest wound, you'd want to use an inclusive dressing and cover with cling film. You can also choose to use a defib pad on the chest. For fracture management, I've got a patient here that has a suspected right tibial fracture. So before I start, I'm going to explain the procedure of splitting to the patient and also gain consent. So I'm going to expose the injury as well as the uninjured leg in order to compare the two. Like so. And I'll also gather history to determine the likelihood of the fracture and what led him to the circumstances that he's in. So I'm going to use the acronym plus discs to assess. So the first thing I'm going to ask about is pain. So what kind of pain he's in, and then I'm going to assess also the loss of function. So I'll try to get him to wiggle his toes and move his legs, and while he's doing this I'm going to be checking for any unnatural movement, any swelling, deformities or any irregularities. So any shortening would then suggest a femur break, and also I'm going to look at cryptus while I'm palpating, and that is the sound of bones creaking or crackling against each other. And also because he has a fracture, I'm going to be aware that the patient could also go into shock. So now I'm going to assess for cardiovascular and neurological integrity. So I'm going to feel for temperature at both of the legs, hoping that they are the same, like so. And also by rubbing his foot or touching his toes, I'll be checking to feel if he can feel any sensations. I'll also be checking for his capillary refill to make sure there is no arterial bleeding or blockages. I'm going to also assess his pain on a scale from 0 to 10 to see how much pain he's in. This will help me determine what kind of pain relief to administer to the patient. The patient has indicated a pain level from 7 to 8, so I've decided to administer Antinox because it's used for moderate to severe pain. So it's a rapid onset between 2 to 5 minutes. It takes approximately 5 to 6 breaths to be effective and is also self-administered. So if I were to administer methoxyflurane, paracetamol or ibuprofen, then I would have to do a drug check with my colleague using the acronyms 5Rs and 4Cs. So a couple of contraindications I've got to be aware of is if the patient is unable to obey commands, if they have a suspected pneumothorax or bowel obstruction, if they've been scuba diving the last 24 hours or have any known allergies. So because the patient is alert and aware, I've asked him if he has any of these conditions, which he doesn't. And this also shows that he's able to obey commands. So now I've got to also inform the patient that there are side effects such as euphoria, sedation, nausea, a metallic taste, and also auditory disturbances. But I'm also going to let him know that this only happens in a few people and that most people are fine. So to assemble Antinox, you want to put the filter and a disposable mouthpiece on. Like so. And you also want to get rid of this after each patient. So you get the patient to bring it up towards their mouth and then take deep breaths in. I will do this and also then do another check of the pain scale to ensure that the pain relief has worked sufficiently before I start splinting. So the patient has indicated a pain level of 2, so I can now move forward and start splinting. So when applying a splint, you want to select the appropriate splint first. So for this, I'm going to use a box splint, which is made out of cardboard. So you can isolate the foot as well by cutting the seams, and this is also one that I prepared earlier. So I'll explain to the patient what I'm going to do, letting him know that I'm going to be putting his leg into a splint to immobilize the leg and protect the wound. So I'm going to ensure that I'm providing enough support in immobilizations. So I'm going to get a towel now and place it inside the box. So I'm also going to be wrapping above and below the fracture site with triangular bandages, so I've already placed them under the splint. So I'm going to then gently lift the leg up and slide the leg into the splint, making sure that it is in the box correctly. I'm also then going to tie above and below the fracture line with the triangular bandages. So, once splinting,
Carry on.
I'll just keep doing this because touching is done, I will again check for cardiovascular and neurological integrity. So I'm going to be feeling for temperature in both legs and touching his feet and toes to see whether he feels sensation. I will also want to then check for capillary refill. When approaching a scene, you want to assess for danger, so your doctor ABCs. And so I can't see, smell or hear any danger, so I'm going to approach the patient. Hello sir. Hello sir, it's the ambulance. So I got no response, so I'm going to check his airway to see if there's anything obstructing. And looking through there, I can't see anything that could be obstructing his airway. So I am going to be looking and listening for 10 seconds to assess his breath. So I got nothing from that. So Nicole, would you be able to start CPR, please? So while she's doing that, I'm going to radio for help as well as attach a defib. So AUT 1 to comms.
Comms receiving, go ahead.
We have an R49 requesting an R50, please.
Copy that.
I'm going to be working around you, Nicole.
Analyzing heart rhythm.
Everyone stand clear.
Do not touch the patient. Paused. Start CPR.
So we start CPR, Nicole. So while she's doing that, I'm going to be putting an OPA in, as well as getting my bag valve mask ready and attached to running oxygen. So Nicole, when you get to 25, can you please count down to 30?
25, 26, 27, 28, 29, 30.
Be 2 breaths, looking for chest rises. Nicole, can you please continue? So during this time, I will be looking for anyone who's seen what happened to the patient, also to see if there's any family or friends around that can help with any contraindications, as well as continuing CPR.
25, 26, 27, 28, 29, 30.
Chest rise. Chest rise, please continue, Nicole. Also with CPR, you want to have 1/3 depth, as well as maintaining 100 compressions per minute with full recall, as well as stopping every 2 minutes.
26, 27, 28, 29, 30.
Chest rise. Chest rise.
One, 25, 26, 27, 28, 29, 30.
Chest rise. Chest rise.
Stop CPR.
So everyone please stay clear of the patient.
Analyzing heart rhythm. Stay clear of patient. Shock advised.
Everyone stay clear.
Deliver shock now. Press the orange button now. Shock delivered.
Everyone stay
Pause.
clear.
Start CPR.